I'm really, really honoured to do this. And when Sean first asked me, I was gripped with imposter syndrome because I'm not a safety person, apart from the fact that, of course, I'm a registered nurse and we are safety people. This is Apollo Beach, and if you heard Kevin's talk this morning, this is where Challenger landed in Florida. And it's been my privilege to visit lots of different safety critical industries over the last few years, partly as part of a Winston Churchill Scholarship Fellowship. And those are the kind of things I'm going to talk about today. What I'm going to talk about won't be unfamiliar to you. They're things that we've talked about all day, and in fact many of us talked about for quite a long time. What I'm hoping to give is a slightly different perspective. So, a bit about me. I am an RN, and I've had a fairly eclectic career, and I started my life as an apprentice rocket scientist. I was an engineer. So when people say healthcare isn't rocket science, I can tell you, it's harder. I've had a clinical career, and I'm very privileged now to be the clinical lead for a matchday medical service at a league football club. I'm going to touch a little bit about that later on because I think there are some interesting perspectives on that, particularly around legislation. And what I do now, this was my first computer, I don't know if anyone remembers these, from the 80s. What I do now is we look for signals in data, quite big data sets, usually from routinely collected healthcare and lots of other industries, to look to see if we can generate intelligence from them. So that's what I do now. I also work sometimes as an expert witness in employment tribunals, so I kind of see a different aspect of that. And I was very lucky a few years ago to gain a fellowship to do something called the Advanced Study Programme at the Massachusetts Institute of Technology. And it was great, and I learned a lot about maths, and we did a lot of really interesting things. But the people that I did that programme with taught me far more. They all worked for high reliability safety critical organisations. And you might be familiar with HROs. So HROs have these characteristics. And if you ever read Kathleen Sutcliffe's book, it's short, but it's really insightful. So preoccupation with failure, reluctance to simplify, I'm going to come back to that quite a bit. Sensitivity to operations, that's what I was kind of interested in. I was interested in the data that people used. Commitment to resilience with a small r, not something that you force on the workforce. And deference to expertise, something else I'm going to come back to. So these are some of the organisations that I've kind of had experience with, or I was quite fortunate that a lot of them gave me their time. I'm going to talk quite a lot about NASA and CERN particularly, big public organisations that carry high risk and do complex work. But actually, a lot of these organisations carry risk and do complex work as well. So, context is everything. I promised I wouldn't mention checklists, and I'm not about to. But one of the things that I thought I'd really kind of think about, it's easy to translate from, this is the way aviation does it, this is the way, the aeronautical industry does it. Let's do that in health. And I think we've seen that this is all very contextual, and to just transplant stuff isn't a great idea. And when I went to these organisations, that's what they all said to me. They said, you can't take what we do and transplant it to healthcare. You've got to understand the context that you work in. So, what I'm kind of going to concentrate a little bit more on is workforce and safety and the relationship between the two. So, I've been to some really great meetings lately on workforce, and I've been to some really great meetings lately on safety. But I hardly ever go to anything where people talk about the two things as being part of one bigger system. One of the things that we look at pretty closely is workload. And workload is really important when you want to look at safety. And workload is driven by demand. So some of those industries are really good at understanding demand. And I don't think in healthcare we're particularly good at understanding it. We do sort of demand and capacity modelling, we look at activity, but we don't really look at demand. So we don't look at its complexity, we look at sort of how much demand there is, but not how complex it is. And those other industries do that really well. Also, our concept of workforce is slightly different. So we think of workforce as the paid workforce, the employees. A lot of other industries think about workforce as the people that do the work. So if you're in retail, if anyone used the self-service checkout? So you're part of the workforce, you're doing the work. I'm always really surprised that we don't utilise, the people that do most of the work probably are patients and carers, and we don't really utilise that intelligence very much at all. So this is the kind of the main message. Key to a productive and safe workforce is understanding that these two things are interrelated. I love this sign. This is from NASA's Langley. This was their journey from safety 1 type approaches post-Challenger to safety 2. So all of Eric Holnagel's stuff. And safety is about people, and you have to consider the workforce. It's really intrinsic to what we do. So the healthcare workforce, I don't know if you knew this, being a healthcare modeller, a workforce modeller, I'm kind of interested in this. We model the healthcare workforce currently like it's retail or like it's hospitality. I don't know if you're aware of that. We've got some interesting ways of doing this. So what we do is we carry a lot of demand and operate, which we don't understand, next to risk. And next to risk, we put a largely what we call a rookie workforce. We put all our inexperienced people right next to the risk. Do you think that's right? Yeah. So then what we do is we ask these people to decide what gets passed on to the experienced workforce. And if you're a rookie, you might not always make the best decision. There's a big gap between the work as done, so Eric Holnagel again, work as imagined, and also from my point of view, the data. These people collect the data, and these people use the data, and actually what happens in between. So what happens here is we generate discontent. Some people will join the experienced workforce, but a lot will leave. So you compare that to a high reliability safety critical organisation, it looks a bit different. So what they do is they've got demand and operational risk, but they keep their experienced workforce on the front line as much as they can. And then they pass work back to their inexperienced workforce. So it's kind of a fundamental difference in the way workforce is modelled in these industries. So we've also usually got a senior middle management that's kind of much closer in contact with this experienced workforce. And we've still got the work as done and work as imagined, but that risk is mitigated to a degree by safety management system. In your organisations, do you use HR data as safety data? Do you use turnover or sickness rates as safety data? No, I'm guessing not. So a high reliability organisation, in terms of intelligence, would use that data generally. So you can see there's some significant differences between the different ways that these organisations work. And from my point of view, I think we should start thinking about modelling our workforce as these workforces do. So this is one of my favourite quotes by Red Adair, actually. It's, if you think it's expensive to hire a professional to do the job, wait until you hire an amateur. So these organisations tend to reward people to stay where they are most useful. And Kevin kind of touched on that this morning, didn't he? So I think that's a valuable lesson that we could learn from these other industries. One of the things that I've learned is that you can't say thank you enough. And when I mean thank you, I mean a meaningful thank you. So you keep frontline experts by valuing their contribution. And in healthcare, I don't think we're particularly good at this. So this isn't just about financial reward. This is about an OT not having to come in 2 hours before our shift starts to find a parking space. This is about saying that a clinical nurse specialist is not worth their money and they've continuously got to prove their worth. We give out lots of messages in healthcare that the workforce doesn't mean very much. It's seen as a bit of an expensive liability instead of a safety critical professions. So I think one of the things that we could also learn is how to value our workforce. A valued workforce is usually a productive workforce. Part of that is really understanding how people work. Lots of these organisations go to fairly great lengths to see how people work best, what motivates them, what makes them come to work. I don't think we do that enough. Most experts in healthcare, or in fact in any safety critical industry, work in meritocracy. They want to do a good job. So creating an environment where people can do a good job and helping them understand what it means to do a good job is really important. Also, having an infrastructure around it is very helpful. So NASA have got things like Ice Cream Club. You can go for an ice cream with your colleagues, creating a bit of time to solve a problem. It's all resource intensive, but actually these organisations see it as a good return on investment. So I think there's a mindset there about investing in our future and investing in safety that we perhaps haven't got to yet in healthcare. The other is using the internal resources that you have. So a lot of these organisations have used external experts and not with great effect. So they've decided to really look inside their workforce, particularly for when it comes to safety. So one of the things that was quite interesting in terms of one of the commercial organisations that I visited was that they had kind of pulled back on using external consultants because it damaged trust in the workforce. They found that it had quite a negative effect in terms of productivity. Making it easy to do the right thing is really essential, and it's, again, a thread that kind of goes through this. This is the Yes If programme at NASA. So we could make a significant change if only we had. So it was about moving from yes but to yes if. How do you facilitate positive change when people are willing to put the work in? This particularly applies to safety, so this is from the Office of Safety and Mission Assurance. Making it easy to do the right thing is essential. It's essential not only for safety, but it's essential in terms of retention. We know a lot of people in healthcare, I think the NMC report, like 26% of the people that chose to leave the register, that's not leave the job, leave the register, did so because of working conditions. So if we make it hard for people to do the right thing, you can see how these things all kind of line up and people end up disenfranchised and then leaving. And that expertise, once it's gone from the system, is pretty much gone forever. I wanted to talk about some of the things that have kind of come on, we've talked about today actually. This is CERN's safety policy. So CERN is a big nuclear installation. It goes across 2 countries. It's a really complex organisation. It's got a huge staff, a lot of which are transient. But I was really surprised when they showed me the CERN safety policy. And it's written on one side of A4. So the response in healthcare usually when something doesn't go well is to write another policy. And quite often people don't really ever seem to read them. So by understanding the workforce and by understanding what goes wrong, it's a lot easier to then make it a lot easier for the staff to do this, to act in the right way. At places like CERN, you get a lot of experts coming together. So everything has to be as kind of slick as you can make it, really. And I think we could learn a lot in terms of efficiency. I was in a talk earlier with James Titcombe, and he was talking about professionalising safety. And all of these organisations have a professional safety infrastructure. So the safety management system, the people that would design things like this, the buy-in from the top is all really slick, and it is all very professionalised. And I think that's something that we really need to think about. Safety is a journey that needs commitment, and it is very much a journey. So I spent some time at NASA's headquarters, and with some of the people that were around when the Challenger disaster and the difference in the 30 years between Challenger and Columbia, and then the time since Columbia and how things had changed for them. But they made it really clear that there is no one magic bullet. This stuff is iterative. It takes time. The other thing that we need to think about is having that commitment that goes across boundaries. I think it's really interesting now that because data's become a commodity, people kind of want to hold on to it, and that's fair enough. But we also, I think, live in a healthcare system that maybe sets us up in competition. So a lot of the commercial organisations, even though they kept their commercial confidentiality, shared safety data. And you can find this on CAA's website and all kinds of areas. But imagine if we were able to access everybody's incident reporting data. What might we learn? I don't know if anybody's sharing data currently, but that seems like a really obvious thing to do. So I think we need to ask, what's stopping us doing that? What barriers are there that stop us doing that stop us sharing our data, analysing our data for the greater good, the way they do in areas like aviation? Talked a lot about just culture today. And everybody kind of says, well, we must have a just culture. And I was sitting there racking my brains thinking, well, how do you do that? How do you do that when you've got a system that's probably not set up for that? So when you look at what these other industries do, and actually this is from where I studied, but it was really about small incremental changes that signalled to everybody that doing the right thing was the right thing to do. That people wouldn't be penalised for doing the right thing. And that's, I think, a change that many people could make, many organisations could make. I often find that what's said and the actions are very different in healthcare. So if we think about what an organisation says publicly, or what it professes to do, and then the actions with the staff, and you see this in employment tribunals quite frequently, they're very different things. Small, incremental, positive steps are one of the ways forward in terms of doing that. Now, I was a bit of a naysayer when it came to human factors, I've got to admit, because I thought it was all about widgets and operating theatres and... sorry. But actually, Steve Shorrock on Twitter actually convinced me otherwise. And he sums up really nicely a commonality within these organisations. You can't have a just culture without working on the work. All of these organisations had paid attention to the work that people did. Quite often I see this, and you often see this when people are overburdened with workload, they end up making a mistake, the punitive kind of system kicks in, and yet nothing changes. And we haven't understood the work. And that's what all of these organisations do. Knowing the workforce, knowing the work, knowing the risk of the work, understanding the expertise you have, really can help you make a safer organisation. I asked them about whistleblowers. I was quite interested in this. And this was somebody senior at NASA said to me, people shouldn't need courage to come to work. And I think that's so true. In all of these organisations, dissent is encouraged. So I think it's quite interesting that there's an open and incentivised way of dissenting. It's quite cordial, but it's there. And I think that's something that we don't do enough. We don't encourage dissent. And I kind of thought, well, why don't we encourage dissent, if it's so positive? And actually, is it because it slows things down? But in a just culture, dissent has value. When I did ask about whistleblowers, what they kind of said to me was, well, if you've got whistleblowers, then something's gone really badly wrong. Whistleblowers are kind of like that, if people feel they need to blow the whistle, if people feel they need to go outside your organisation, something's gone really badly wrong. And I think particularly on social media and areas like that, I quite often do talk to people that are whistleblowers, and their experience of trying to, it kind of always starts in the same way. They try to raise a concern. And is it because the infrastructure's not there? The safety management system in most of these organisations gives people an impartial route to someone where they can express their concerns. And I guess in healthcare we don't really have that. So one of the things that really impressed me was the transparency. So you might not be able to read this slide, but you're very welcome to have these. Speaking up is seen as, not to speak up is seen as socially unacceptable in a lot of these organisations. So if you don't speak up, You're not seen as doing the best for your colleagues or the service that you're providing, which I thought was really interesting. It's completely the opposite to us, I think. I quite like this one, actually. You're not nearly as smart as you think you are. So this is very engineering. But I think there's a very different perspective in terms of the relevance and the value of speaking up. So even if it might cost you something, you still have to do it. So that's quite interesting. I just wanted to touch on incivility. So I haven't heard very much about incivility today. But this was one of the things that really kind of struck me, that the chief of safety at CERN said to me, a large operational risk could evolve out of an argument over a car parking space. And there's a campaign called Incivility Kills. I don't know if you've seen it. But we don't handle incivility at all. In fact, I think sometimes in healthcare, we actually reward it. So for being, you quite often hear it, but they're a good clinician, or they're a good, but actually they're quite rude. Does that make you a good clinician if you're rude to your colleagues? So what a lot of these organisations do, they have peer support, mediation, try and kind of figure out what's going on. So it's not a punitive system. It's really about supporting people. They might be having a hard time at home. There could be all sorts of reasons why people are rude to each other. But what really impressed me was that they take this really seriously. And they don't see it as a positive attribute. They don't see incivility as a positive attribute. And I think that's actually quite important. So transparency is kind of a key aspect of most of this. So this is the Office of Safety and Mission Assurance at NASA. This is their website. You can go on here and you can see everything that's going on to the public. It's all open to the public, which is great. Being open and transparent when things don't go well is seen as kind of axiomic. It's seen as what you should have to do, which is interesting. The other thing is about trusting the workforce. Deferring to expertise means you hire people for their skills. You don't hire them for their skills and then tell them to do something else and then not trust them to do it. Trust decreases complexity. So, you hire an engineer to do an engineer's job, they do an engineer's job. But that level of trust, and I think Kevin talked a little bit about that this morning, is something that runs through all of these organisations. I was also really impressed that whoever I spoke to was quite open with me. They were open about the difficulties as well as the positive things. Sometimes when you go to NHS organisations, you kind of get the grand tour, and people say really good things about everything. And you think, it can't be that good, can it? But a lot of these organisations are very open about the fact that things don't go well and what can we learn from them. And it's like a mindset. So it's worth going on OSMA's website, actually, and having a look round. You'll see everything from, how they sort of move stuff around the organisation to their big stuff about buying in from the top, a commitment to safety. One of the things that all of these organisations had was they all had buy-in from the top. Whoever was the boss of the organisation was very open about their position on safety. Sharing a common goal was also another feature of most of these organisations. So we, not I. Now, some people say that can be an issue when it comes to accountability, but shared missions and goals means everyone had a stake in what was going on. These are from Langley as well. This was about NASA safety culture, about reporting culture, a just culture. Reporting seen as quite important. Reporting is where the signals come from when things are not going well. It's quite interesting because we mine datix, and what you see is when there's been, quite often now we've started to mine datix when there's been some sort of change, when there's been more expertise deployed, for example. And you always see reporting going up, which is quite interesting. So I think that sounds like it's probably a an aspect of that kind of positive culture. So I thought I'd just touch on good policy and legislation use. So I thought I'd bring it back home. This is football. This is where unfortunately, this is Hillsborough. So a lot of our legislation is tombstone legislation from the Hillsborough Stadium disaster. But I work at a football club. I work at Millwall Football Club. And I am very clear about my responsibility. I'm very clear about the stadium manager's responsibility. I'm very clear about, we have something called the Green Guide, and it tells us about staffing and safety and all of these things. It's all mandated by law. Now, I can deviate from the staffing, but I have to give a reason for doing it. So you can have justifiable deviance. But what that kind of policy and legislation gives me is a framework in which to practice. And that's what all of these other organisations had. I find it incredible that I have to have a safe staffing ratio at a football ground, but I don't in a hospital. So I think that's what we're missing. I think we're missing that legislative framework. And legislative frameworks don't have to be absolutely crushing. They can be really helpful. In fact, I think this kind of stuff really helps us. It helps us to provide a safer service. The other thing is about credible and visible leadership. So everywhere you go at NASA, they all know Charles Bolden. Unfortunately, Charles is no longer the head of NASA. The new president has put somebody else in. For the first time, not an astronaut or an engineer. So it'll be interesting to kind of follow this as it goes along. But that thing about visible, credible leadership, every organisation I went to, they knew who the boss was. They knew who was responsible for what. And I think those clear lines of accountability in terms of the workforce are actually really important. So just to end, just to come back, because this is the point that I think is most important. The key to safe and productive work is understanding the relationship between safety and workforce. I really do think that we need to stop looking at the healthcare workforce as some kind of expensive burden and start seeing it as safety critical. So I think it's a difficult move for people to make. I think it's probably a really difficult move for people like finance directors, actually, to do that. But otherwise, we've got an impending workforce crisis, and we'll just be really thinking about how we're just kind of feeling our way. So I'll leave you with the thing that I like best about this, actually, is that there's a lady at NASA who's the head of safety called Tracy Dillinger. And she said to me, if you don't have these plans, then people defer to hope. But when failure is not an option, hope is not a plan. Thank you.
Thank you, Alison. That was fantastic. I'm so pleased when a choice first speaker comes off. That's wonderful. I want to throw it open to the room for questions, and we do have people with microphones, so I know we're going to use a bit of Slido as well, but does anybody have a burning question for Alison? I've got some of my own, but if anybody wants to be brave and ask Alison a question, anybody brave enough? I can't quite see. There's a gentleman over here in the white shirt, if someone can see that. Let's start with him there then.
It was a lovely talk. I'm a consultant physician. What you said about the openness from NASA and those safety critical organisations means that people can really see what they're doing and how they're deciding things. I think those who run NHS organisations from the bottom up to the top are in a state of fear, in that it has been the case that chief executives have been basically bumped off when an NHS organisation gets a red rating from the CQC. And sometimes those of us who work in the NHS get told things from those very senior levels which are simply not true. So we get told things like, there are no beds, which we know is code speak for just, we're very busy. But we actually get told lies. So what do you think about the nature of the kind of intra-organisational communication in the NHS that could move a bit closer to the kind of styles you were talking about from America?
I think a lot of it actually is the way that now organisations are set up to be perhaps far more competitive than they need to be. A lot of healthcare organisations are quite competitive. So does it really need to be that way? So we've got a lot of the issues around commercial sensitivity, which you get in any industry, not just in America, but around the world. So people like Boeing, but they share safety data. So that's quite a cultural leap, I think. I think that a lot of people maybe who work in healthcare and are leaders in healthcare are not perhaps aware of the way these relationships work. I mean, one of the things that prompted me to do this was I was told by a senior decision maker that there is no relationship between safety and staffing. So I think it's really about challenging that to a degree. But also the fear, I know the fear is palpable in organisations sometimes. Whether it's a perception of fear or consequences, people see what happens to other people. That kind of behaviour, I kind of failed to see how it can be productive. I can see why people do it, but I don't understand why people perceive it to be productive.
And there's a question on Slido, Alison, which says, how can we put the experts nearest the risk when we've spent years de-skilling people and constantly reducing skills during skill mix reviews to save money?
I think that's a really important point. We're looking at the healthcare workforce currently as being a mass skill dilution to try and keep the volume up in terms of that there seems to be a direction of travel that's sort of most hands for least money, and including that is the frontline skill dilution. How do we do it? One of the ways we need to do it is retain people into the system. We also need to offer clinical people, or actually any area of expertise in healthcare, actually not just clinical, but a way of staying in their work where they are most useful and incentivising it. I mean, nursing's a great example of this. If you want to get on in nursing, you have to be a manager or maybe go into education. You don't get a really good band 5 staff nurse who then can get promoted to a band 6 without having to apply for another job. We don't do that. Whereas in other industries, I'm thinking about the oil industry, they will pay people to stay in the same job for 20 years. They'll pay them more money. So, it makes more sense, really.
I was struck by a conversation I've had with lots of people over the years around workforce and safety, and I've written lots of articles where people point out the association is real and obvious and it exists. But I wonder if what we really need to be doing is making the economic case for safety and the economic case for some of the things that we see other organisations doing. Is that the way we persuade senior decision makers and the Treasury and other people like that to actually start buying into this? Because I wonder if there's a temptation for researchers and people in your field who will they'll describe the association, but they're not making the economic case for safety. And I wonder if that's what we need to be doing. Yeah,
I mean, it's like the Red Adair quote: if you think it's expensive to hire a professional to do the job, wait until you hire an amateur. I don't think we're very good at making the economic case. I don't think we're very good at helping people understand that this is a good return on investment. And it also depends on what your outcome is. So if we're working in particularly the English healthcare system where it's activity driven rather than outcomes driven, I think that doesn't help actually, because it's just about getting more activity through the system. That can't be conducive if we don't think about what the outcomes are. And we've seen what some of the outcomes are.
Now, we've got a really varied audience at the Patient Safety Congress, from very senior to very frontline. What could all of these people do when they get back to their workplace to try and make it a little bit more closer to NASA?
That's a good question.
Everybody wants their ward to be like NASA, right? So.
I think one of the things that when I speak to maybe the workers imagine, workers done aspect, I think the people that imagine the work, that gap seems to be quite big in a lot of organisations. Not all of them. There's some great ones. So the stuff about rookie factor that we talked about earlier. The Boston Children's Hospital, for example, have, so in safety critical industries, you wouldn't ever want more than 20% of your workforce to be rookies, so people qualified less than 2 years. And Boston Children's Hospital have done this in their intensive care unit, and I saw some results from one of their studies that shows if you don't have more than 20% of nurses as newly qualified, then morbidity and mortality, reduces. It's great. I don't think leaders necessarily want us to give poor care. I think they don't understand. I genuinely think a lot of them don't really understand the relationship. So the thing that I would ask everybody to do is go and articulate the complexity of the work that you do. I think that would help people an awful lot. We still need to figure out a way of communicating it, I think. But I think each of us can be an ambassador for safety in that sense.
That's an interesting point. Food for thought for everybody there. I'm afraid we're very close to running out of time, so this will have to be the last question. But you talked about high reliability organisations, and one of the bullet points there was preoccupation with failure. And I thought, the NHS is a high reliability organisation. It is preoccupied with failure, but it obviously isn't very good at the other bits. And one that particularly struck me was deference to expertise, which is kind of what you just were mentioning there. But in my experience, this comes from our senior leaders, the chief executives of NHS organisations, the chief nurses, etc. That's a real problem, isn't it, if our professional leaders are actually the ones exhibiting a lack of deference to experts.
Yeah, I mean, I think if people don't realise the assets that they have, then they're not going to use the assets that they have properly or to the best effect. The issue about preoccupation with failure, actually, I think the NHS is a long way from that. It was preoccupied with harm, but not failure. So thinking about, as James Reason, I think it was, who said that safety is more than the absence of harm. So a lot of these organisations, they're preoccupied with failure, but avoiding failure, so understanding the work so that you can avoid it. So I don't think we're there yet, actually. There's a sort of, I was listening to somebody else talking about near misses, and, a near miss, you think, oh, God, near miss. You've dodged a bullet. But actually, what happens next? We don't learn from that. So if you don't learn from the near misses, then when something does go wrong, you don't really learn at all. So, yeah.
Well, I don't know about you guys, but this has been absolutely fantastic. Alison, that was a brilliant lecture. You've knocked it out of the park. I don't know how we're going to top it next year. But everybody, I think she deserves a very good round of applause.